Welcome, everyone. Happy first Friday of summer. Hope you're all doing well, and appreciate you taking time out of your day to join our wonderful community here. We're going to give it another minute. Our custom is to start around 12:17 when people transition in. Give it another couple seconds. Well, let's go ahead and get started. Thank you again for joining. And I'm Chris Rhodes, co-lead for Project ECHO Dementia. Let me go ahead and share my screen. Again, thank you all for taking time out to join. Hopefully you can see that okay. Looks like it's sharing all right. So here's our agenda for today, kind of our standard format. We'll do a couple of brief opening notes and reminders. We will then, if we have a couple of minutes and some new folks, happy to do introductions, or please do put your name in the chat if you're joining us for the first time. And we have the great good fortune of a wonderful didactic by Hilary Wang, Post-operative delirium and best practices for prevention and management, and then a great case from Cindy Bevan, and we will get started on that after the didactic. A couple of reminders. If there are multiple of you at your site, please enter the names of all attendees into the chats. And I think we're all pretty well versed with muting the microphone when not speaking, but please do remember, if you could, to say your name, especially if you're new to us, so we get to know you a little bit better. If you have the capacity and the bandwidth, having your video on is great, but also understand that you might not be in a place to be able to do that. A couple reminders about some other ECHO and educational resources. So there's the TBI Behavioral Health ECHO that occurs on the first and third Fridays, Psychiatry and Addictions ECHO, Telebehavioral Health Training Series, telephone consultation options for chronic pain and opioid prescription questions, and then a telepain series, some work our colleagues are doing. Also some reminders to ensure that we are protecting PHI, and we have taken efforts to make sure that there is none included in the case presentation. I want to just remind folks not to share anything that may be revelatory. We are recording all of our sessions and they are available. So if there's a prior session, feel free to go back and check that out. Or if you come in late at any time, you can always find things that way too. And we will, as always, be sending a 1-minute post-session survey, and really do value your feedback so much as we try to continue to improve this. It's great to think about how it's changed, and I think improved over the last 3 years that we've been in full swing. Let's see. And then just another reminder, if you are interested in Dementia Friend rack cards, go ahead and throw your name in the chat or reach out to us after the session. Happy to send those. I'll also share that the recently updated Dementia Roadmap through the Dementia Action Collaborative is now available and has been printed. So there's some other resources. We'll come back around. I know we have a session in the near future, not too distant future, I guess it's December, where our own Lynn Cordy will be talking about the updates to our state plan. And along with these other wonderful didactics that are coming up over the next several months. We have had the great good fortune of having a number of cases over the last few sessions, and I still think it is such a critical part of the experience and the learning for all of us. So would welcome your cases, and we'll love to make it as easy as possible to present. We are accredited for CME. We don't have any disclosures, either the planning committee or our speakers today. Here's our hub team, and here are our wonderful community members. The most updated numbers are there have been 140 unique individuals who have participated in this over the last 3 years. Some of you come regularly, some every once in a while. All are welcome, and we value all of your participation. And again, it's been such a great experience. All right, and with that, I will turn it over for our fantastic didactic. And I'll stop sharing here. And thank you, Dr. Wang, for your time and expertise and bringing this forward today.
Awesome. Thanks for having me. Let me share my screen and bring up my slides and give that a second to load up. Thanks everybody for joining. Today, my talk is called Post-operative delirium, but it's sort of a mishmash of lots of different thoughts about delirium and its interface with dementia for this crowd. I'm one of the neurohospitalists at the Providence Swedish Cherry Hill campus and the other campuses at Swedish. I'm also the quality lead for our Swedish Neuroscience Institute and enjoy thinking about this topic and the challenging ways of helping our this patient population when they're admitted to the hospital. So, okay, there we go. Just to have a bit of an agenda, I'll start by just doing some definitions about delirium and the detection of delirium to set the stage. We'll talk a little bit about risk factors and ways in which it's been studied to prevent delirium, and then try and spend more of the time thinking about this concept of the risk of developing dementia after an index case of delirium and the interplay of patients with pre-existing dementia and their underlying risk for developing delirium in a hospital. And hopefully a robust discussion with questions at the end, because this is a challenging and still very much in evolution field in neurology. So in thinking about delirium, you know, the classic DSM-5 definition, which is at the top bullet, is that this is an acute and fluctuating disturbance in a person's attention and cognition, which is not based on a pre-existing neurocognitive disorder. You know, when I hear that phrase, it's a little confusing what they mean. I think at the core, the idea is that you are not, diagnosing anybody in the hospital with dementia because of their cognitive changes in that acute time frame, because so many people can develop a transient stage of delirium. And so I think that's the distinction that the DSM-5 is trying to achieve. But I think the field as a whole is really trying to move towards different nomenclature of thinking about delirium, because currently this one word is a catch-all for quite a few different things that are going on in the brain. And so some people are positing the idea of this post-operative neurocognitive disorder spectrum, NCDs, many acronyms as you study delirium, so it can get confusing. And the beginning of which is a more contained entity called post-operative delirium that can happen strictly within a hospital admission, followed by weeks to months of maybe delayed neurocognitive recovery before someone returns to baseline, versus a person who has post-operative cognitive dysfunction where they have the acute delirium. It takes them many months to recover, but that recovery never quite gets to the same baseline level of cognitive function as before, and that this is a gradient by which a person, may be on. The other way of thinking about this nomenclature is looking at the patient population that we know is most at risk for delirium, which is patients with pre-existing dementia. How can we separate out what is the underlying dementia and what is the delirium? And proposing a new idea of separating out delirium superimposed on dementia, or DSD. Certain studies that are more recent have looked at cohorts, and they estimate that about 31% of people, all comers with dementia, might experience delirium superimposed on dementia at some point. And this could be as high as almost 50% if you're looking at strictly a hospital-based population of patients with dementia. So a huge amount of overlap, and I think trouble even in the field of experts of defining exactly where to draw the lines between delirium, dementia, and the overplays. And we do know that delirium and all of its facets affect quite a high proportion of surgical patients. Depending on the studies you look at, I'm quoting 10 to 50%. I've seen as high as 80% in certain studies of surgical patients. And these patients who'd experience delirium, post-operative delirium in the hospital, they have associations with increased mortality, longer lengths of stay, higher 30-day readmissions. Pretty much all of the bad metrics that can happen to this vulnerable population tends to happen a bit more in delirium. And so I think it's an important field to think about, and one that I think has less emphasis than other conditions in neurology because it is still somewhat poorly defined. Looking at the right side of the screen, this is a nice graphic from one of the sort of leading experts in this, a paper in 2009 by Fong et al. That tries and lays out the three major contributors to the biochemistry and the neurophysiology behind delirium, as far as we know. A lot of ongoing research about biomarkers and thinking of how to define and measure delirium. But on the left-hand side of that graphic, you see that precipitating factors of things that can happen to a patient in the hospital. So they're hypoxic, they have metabolic derangements, all of the things that you think about for toxic metabolic encephalopathy. That leads to an overall impairment of cerebral metabolism, which then changes the synthesis and release of neurotransmitters in the brain, which disrupts the balance of your neurotransmitters and the efficiency and typical nature of your synaptic communications in the brain. Drugs that people get in the hospital for a variety of reasons can also change that interplay. And on the right-hand side, medical conditions that land you in the hospital, such as getting a surgery, right? An open surgery, which can induce systemic inflammation, or having a bad infection, or any number of things, that can all activate some primed microglia in the brain, which then changes the level of cytokines in the brain, and again, disrupts that balance of neurotransmitters to create this transient state of delirium. As far as people can figure out from the studies, just to kind of summarize the key neurotransmitters, it seems as though there's an increase in dopaminergic activity in the brain during delirium and a decrease in the cholinergics. So not enough cholinergics, too much dopamine, things are not in balance, and people experience and display delirium. A lot of tables in my talk that I'm not going to go through, kind of visually busy, more for reference, because I find these tables to be very well done and helpful in trying to delineate delirium from other related entities. But in thinking about delirium juxtaposed against the subtypes of dementia that we're familiar with, in the red text, in thinking about delirium, a lot of the definition really has to do around the phase, so it being acute and episodic, around the amount of fluctuation, particularly in attention and in people's organization of thought, and the idea that this is something that can usually reverse, after a period of time, as opposed to all the other types of dementia out there, which are chronic and progressive and don't, have steps back so much. I think that at the bottom of this table, in thinking about the types of psychomotor changes and agitation, I think the behavioral disturbance is something that is much more common in delirium than in some of these other dementia subtypes. I want to take a brief detour and just talk about the term sundowning, because we're defining terms. Sundowning is, as best as we can define it, it's this emergence or worsening of neuropsychiatric symptoms, particularly in the later afternoons or early evenings. You think about behaviors like anxiety, agitation, aggression, wandering, yelling, hallucinations. These are the types of behaviors that if you ever work on the inpatient side, nurses are sending pages about, 8 p.m. to tell you that the patient is not doing well. I think it's really interesting because as far back in my medical training as I can remember, this is a term that's been thrown around for quite a few patients in my care. But it's not actually a formal DSM-5 diagnosis. I think everyone uses the phrase, everyone acknowledges it as an entity. And in fact, we treat it very frequently with pharmacologics, even though it's poorly studied. But it's not actually a defined thing. I think there's a huge amount of overlap between sundowning and delirium. And as best I can parse out in the literature and in my own head, I think of sundowning as an entity that is even more short-lived than delirium, where it's strictly isolated to this phase of day. And in the morning times, people don't seem very delirious. They can have, sustained periods of alertness and attention without there being quite as much fluctuation as delirium. But I think that it's probably a subset of delirium that we're just calling out as being very frequent in populations. In thinking about the pathophysiology of sundowning in particular, this diagram on the right by Wall et al. In 2019, I think is beautifully drawn. And it shows that probably the underpinnings all do have to do with your circadian rhythms and the pathways in the brain that drive that, particularly activation of the suprachiasmatic nucleus. And I think the latest in thinking about this is that in autopsy and other studies of the brain, it's thought that dementia can have, particularly Alzheimer's dementia, can have neurofibrillary tangles develop in these particular centers in the brain, reducing their activity and efficiency and predisposing you to having issues of sleep wake that lead to sundowning. And so there's that underlying neurophysiology. Moving our attention to defining and detecting delirium, there are dozens of scores that are out there that are used in hospital settings to try and define and capture the delirious population. I'm drawing attention to this one in particular. It's probably the most common and the most widely validated in a hospital setting. I don't see why it couldn't be used outside of the hospital, but I've never seen it be done. It's called the CAM, or the Confusion Assessment Method. This particular version that's on the left-hand side of the screen is called a 3D CAM. It's meant to be done within 3 minutes by nursing staff or really anybody assessing the patient on a regular basis. And it focuses on 4 core features that I'll just quickly walk through. Feature 1 in defining delirium is really, was there an acute change in this patient's cognitive status, and is there fluctuation? So the testing is pretty simple. Either the patient or the family is just endorsing that the patient is confused or disoriented, or they're having hallucinations, or the staff is just observing the patient having these behaviors, and that's a yes or a no. Moving, the next is there this cardinal feature of inattention in the patient? And so any one of these tests to test for attention can be done, or multiples for redundancy. We can do digit span backwards, 3 backwards, or 4 backwards. You can do days of the week backwards, or months of the year backwards, anything where the patient really has to retain information and sustain attention to see if that's been affected. Or if you can't get them to participate in a formal test, you can see if their thought is linear, if they're easily distracted by stimulus in the room, to get a yes or a no. And then following that, the 2 other features of disorganized thinking and altered level of consciousness in thinking about orientation to time and space, and the flow of how they're speaking with you, and whether or not they're excessively sleepy or excessively activated or agitated. Delirium can come in several different forms, where someone is agitated and hyperactive. Someone is just sleepy and not quite themselves and drowsy in bed, hypoactive, and then a mixture of the 2, because again, fluctuation is really key in defining delirium. When you look at the success of this assessment, the performance, particularly in patient with dementia, is quite good. Its sensitivity in a study was about 0.95, with a specificity of 0.86, so quite good and fast. And it's also just been validated in other 18+ populations. And so I think is a useful tool to have in the hospital to really bring out this as a diagnosis. And just one other score to quickly go through, in thinking about the difficulty of untangling delirium that's superimposed upon dementia, excuse me. Different groups have really tried to address this. This is a different score called the 4DSD, which is, I think, just to very, very factually, it's 4, delirium superimposed upon dementia. It's meant to be used particularly in patients with a diagnosis of moderate to severe dementia. You score it out of 12. And if somebody scores above 5, that tends to have at least an 80% sensitivity and specificity. It's a newer scoring system. I really haven't seen it be used in clinical practice, more in a research setting. But again, just trying to say that people are really trying to get at, how can we tell if someone is having difficulties above and beyond what we would expect for their baseline? Thinking about risk factors for delirium, and I think that it's part of the struggle of this field to really try and focus on, what can we do to figure out before the delirium is happening and we're diagnosing someone with it? How can we say, is this person who's going to come in for an elective hip surgery, are they going to develop delirium? There are many, many, many factors that go into somebody's risk, many of which have been studied, and I think really points at how systemic the issue can be. It's a health systems issue. It's not just one person in one particular way. Lots of different things can affect this. On the left-hand side of this table, you have possibly modifiable risk factors for developing delirium, either once somebody's in the hospital or immediately preceding. People can have hearing or vision impairments. They can be immobilized. They can have catheters in place. There are medications that they can be given or they can already be taking that can predispose them to developing delirium. Obviously, having another neurologic disease on top of everything else, like a stroke, puts people at risk. and other comorbid conditions that can change that metabolic balance and disrupt the flow of neurotransmitters can also make people at risk. And then even beyond that, just pain and emotional distress has been shown to have, which is hospital stays usually include some of that, has an association with delirium, their environment, how much sleep they're able to get. So there's many, many things that are potentially modifiable and some that are not, including in red on the right-hand side. Dementia in and of itself is a risk factor for developing delirium, or just elderly age. Older people are more at risk even without a pre-existing diagnosis of dementia, whether they've had delirium before, if they fall in. Men tend to get it a little bit more, and certainly if there's underlying renal or hepatic disease that affect the body's ability to properly metabolize, drugs and anything, that can make it difficult to avoid delirium. This table, again, not to get into the nitty-gritty, I think is a nice summary of laying out factors that can predispose you to developing delirium. And then once you are in the hospital, or once you're in a position where you're at risk, what can precipitate it or make that delirium even worse. And so in red, you have dementia, which, just to give people a sense of the scale, once you have dementia, it's felt that your relative risk of developing delirium on a medicine floor is somewhere between 2 to 5-fold, above and beyond somebody without dementia. And on a surgical unit, that studies have shown it's around 3. So again, I think that 3 to 4 relative risk factor feels about right based on a number of studies that have been done. And then in thinking about medications as something that precipitates delirium that might be within a clinician's control, if you use more medications, so polypharmacy runs a risk. If you use psychoactive medications, which commonly we do to try and control problematic behaviors, that can in fact upset the balance of neurotransmitters more and sometimes prolong delirium inadvertently. And medications to try and reset the sleep-wake cycle can sometimes also backfire in an ICU setting and make the delirium worse and more prolonged. And so it's a complicated task, I think, to address. How do we deal with delirium in the moment? And there's just so many things. Switching gears to talking about this idea that there is cognitive risk after delirium. So, I think it's been a struggle in this field for decades now, to answer the question of, do we think that delirium is just a marker of somebody who's vulnerable to dementia, right? So this is the sort of pre-dementia brain expressing itself as delirium, or do we think that delirium actually, because it's happening, causes or provokes certain neurochemical pathways to lead to dementia, that if you had avoided the delirium in the first place, maybe you would not have developed dementia? And no one knows yet. We don't know. There are studies out there going back to the early 2000s looking particularly at post-operative patients, because that's a nice cohesive group where you look at people who develop post-operative delirium, and some percentage in this particular small study in 2008, 53% of the post-operative delirium patients suffered cognitive impairments a few years out, compared to just 4% of the non-delirious patients. This association, I think, has been recognized for a long time. Studies like this don't really get at the cause and effect so well. But in people, in a relatively recent review in the Lancet of delirium in the elderly, which is summarized in this table on the right, in lots of different patient populations in the hospital, surgical and medical, there is, again, this relative risk of developing dementia as an outcome of the delirium, where it seems, at least from a time sense, there is this increased association in delirious populations of developing dementia, a diagnosis of dementia down the line after that original hospital stay. And so there seems to be this possibility. More recently, when we think about this cognitive risk, there was a 2021 meta-analysis of 6 studies that looked at about 900 patients. That again, it showed that delirium was associated with this increased odds of developing new dementia, as opposed to people. So these are people without pre-existing dementia diagnosis, developing new dementia compared to patients without. And the 2022 cohort study, which is, I think, the largest one that I found in my knowledge of this, looking at almost 13,000 patients in, I believe, Scotland. They tried to do some really fancy math and look at the cumulative incidence of dementia in patients who did experience their first case of delirium above the age of 65, who did not already have a diagnosis of dementia. And they followed these people in the chart. It was a retrospective cohort study done in I think 2020, going all the way back to 1986. And they found that, when they follow these patients, 27% of that patient population ended up having a diagnosis of dementia at the date that they studied. 45% actually had died by that point in the study without a diagnosis of dementia, and 28% were neither dead nor had dementia. And so those patients were censored from the study. And in looking at some analyses, they concluded that it seemed like a first episode of delirium after age 85 has a 9% risk of developing dementia at 6 months, a 13% risk of having the diagnosis happen at a year, and a 31% risk at 5 years. In comparison, they looked at the opposite direction and say, is delirium associated with mortality in a numerical way, which there's been relative risks of delirium leading to higher mortalities in patients. And they also found that there was about a 49% chance of death without dementia at 5 years. So certainly delirium is associated with some pretty poor patient outcomes in this study. And maybe I think in a positive sense, when you look at this little chart on the bottom right-hand corner, delirium, I think, has been an underdiagnosed phenomenon for a long time. But the bar graph at the bottom is just showing that from 1986 to 2020, the number of discrete diagnoses of delirium has really gone up quite a bit. And I don't think that's reflective of an increased prevalence of delirium, but just an increased recognition of delirium in the community, and doctors being more aware of it happening. Quickly touching on some delirium prevention guidelines, there are societies out there that have issued consensus statements for trying to address the risk of delirium and how can we do our best to prevent it. There's thoughts going back that maybe up to as much as 40% of delirium cases are potentially preventable. And with such serious patient outcomes, it's thought that we should really try. Unfortunately, there's not a lot of really strong data or really strong interventions out there that are proven to work. Pre-hospital interventions to consider, when I look at that, those consensus statements are identifying people at high risk, particularly if they're electively going to be hospitalized. Seems important to just frame the risk for those patients in particular and focus, possible interventions for them. And then I think maybe, the addition of delirium as a part of informed consent. I think this is a really serious potential outcome from entering the hospital, as serious as blood loss or any of the other things that make it into informed consent. And I think it should be more strongly considered. Just to give you a sampling of all the research out there that's ongoing and failed. There are many studies out there that are unfortunately negative trials for ways of addressing delirium in the hospital and shortening it, or ways of preventing it. People have tried to use Raveltion, which is, in my mind, fancy melatonin, and which was a negative trial. People have looked at different first and second generation antipsychotics to try and treat delirium, which do not have good effect. Rivastigmine has been studied with initially promising results, but then subsequent not promising results, all trying to tackle those dopaminergic and cholinergic pathways. And so far, there's not been a proven method of treating delirium. But people are looking at EEG studies to try and identify delirium earlier and with more accuracy. People are exploring ways of improving anesthesia technique to try and reduce delirium risk after surgeries, and other ways like Doppler, transcranial Doppler of trying to identify delirium that's particularly superimposed upon dementia so that we have a clearer sense of who's affected. Penultimately, I like this figure, which is from a recent review in 2022, in thinking about this interrelationship between delirium and dementia. In the middle, you have the delirium or the no delirium. And on the left-hand side, you have patients before delirium, and you think about things that can precipitate delirium, things that make the brain particularly vulnerable. And either they're going to gain resilience because we were effective at utilizing some prevention strategies, or they go into delirium. And once you're in delirium, there's this chronic phase where you have neuronal injury and dysfunction that lead and cycle with inflammation that may or may not lead to dementia, may or may not accelerate Alzheimer's pathology. And I think it just highlights the fact that I think more attention should be paid to this phenomenon. And to end on a perhaps positive and empowering note, there's not a lot that I can give this audience to walk away with surefire things to prevent delirium in the community for these patients before they come in. I think one German group of anesthesiologists back in 2021 tried to summarize some guidelines to think about medications before coming into the hospital. I think it's a useful framework. I don't know that this is particularly evidence-based, just based on the literature. But the thought is, substituting with what we know, higher risk medications like benzodiazepines, certain tricyclics, certain SSRIs, for it seems like mirtazapine as a tetracyclic alpha-2 adrenergic seems to be relatively safe and lower risk in developing delirium. If we can substitute certain medicines before an elective admission, perhaps that can be helpful in moving the needle of risk. And similarly, for patients who are on opioids for pain control, trying to move their prescriptions, except in palliative care, to hydromorphone, which seems to have the best safety data out there for lower risk in delirium in hospital stays, could perhaps make it into part of the pre-admission pathway in thinking about how do we get these patients out of the hospital without index delirium. So wanted to stop there and just welcome questions and discussion and thoughts about this complicated topic.
Dr. Wang, thank you so much. That was a wonderful presentation on a very complicated topic. And one, I think we've all got stories of how scary and confusing this is for families, particularly when people don't get back to their neurocognitive baseline after hospitalization. And for something elective, that's certainly challenging. So yeah, we've got plenty of time for questions. I'm sure there are a bunch.
Is there a time frame in which delirium is defined post-operatively?
Yes and no. There's not like a date by which, like a month later, we're not going to call it delirium. I think that probably if you're looking at more than a few days to a week after the index surgery, we're not going to call it post-operative delirium. But I think this is part of the problem with describing delirium, in which there's just so much overlap between these different terms that we use. I personally don't think it particularly matters how many days after the surgery. I guess maybe in an outcomes data perspective, we care if we want to blame the surgery. But I think the conditions that the condition the patient is in after the surgery, no matter whether or not it's primarily due to the surgery, can cause the delirium. Delirium, I forgot to mention, in defining it, delirium typically lasts between, I think, like two to 4 days is sort of an average duration of a delirious episode, but it can stretch out, for weeks and weeks. There are delirium cases that are still the case a month, 2 months after they start developing the signs before they kind of go back to some level of baseline. And we do know that the longer your delirium is, or the more times you're delirious, that has a cumulative risk in patients. So it's always better to have shorter delirium if you have to have it, and not as many cases. Did that answer the question? I'm not sure I did.
Yeah, it does. I work in a perioperative clinic, and for all of my patients that have high risk factors, being over the age of 65 basically is all I use. We have a great handout that we go over with our patients, made by the American Geriatric Society. And it says it encourages people to not plan on making any major decisions after they have surgery. It encourages them to bring all of their sensory devices to surgery. So glasses, hearing aids, and dentures. And it just encourages them to just basically take good care of themselves before they go to surgery. And after surgery, if they notice that they're thinking differently, and if I have patients, family members there with them in the clinic on that day, I say, if you notice that they are thinking differently, make sure to mention it to your doctor so we can try to help you. But of course, after I always say, so that we can try to help you, I'm wondering if they're going to say, well, what would they do? If something was different. And kind of what I'm taking from your presentation is that we don't really have any medical interventions besides just trying to reorient them with their sensory devices, like sleep-wake cycle, these kinds of things.
Yeah, I think I go back to, so you're right, there's no surefire thing, right? I don't think there's anything in the literature that I'm convinced by is something we should be doing empirically and we'll fix, will be the silver bullet. But I go back to that slide where, you had the underlying neurophysiology of of your delirium. And I think it's just really honing in. If somebody is still delirious, to me, something is still off, right, about that balance of neurotransmitters in the brain. And so to kind of go back and say, okay, of the categories that are potentially addressable, are we missing something metabolic now, right? It should be the case, and I think it should be the hope, that for most patients, within a few days, they're out of that delirium episode, right? They're improving. If they're not, then I think rather than kind of throwing our hands up in the air and say, well, there's nothing we can do, kind of going back and reinvestigating and saying, okay, are we missing the fact that after surgery, there's something simmering below the surface and the delirium is really showing us that there's something going on, right? And so I think paying attention to it is an excellent start. But then as part of that discussion with their doctor after, with their surgeon after, saying, hey, they're still delirious. Are we missing some complication of surgery, that we're not thinking about? Assad Kazemi?
Yes, thank you. This was such an excellent presentation. I'm just wondering, and again, following up on the previous colleague who is working in pre-operative setting evaluation. The last I checked, there's no evaluation or looking at the medications during the pre-operative period at baseline is not part of any pre-operative assessment tool. And we know that medications that people are taking at baseline play a huge role in post-op delirium. Is there any tool that would include or does include reviewing of medications preoperatively for elective surgeries, where we have some time to work on these medications and look at alternatives that could potentially be less harmful and wean people out of dangerous medications and get them ready for surgery?
Yeah, so there's no validated tool that I know of, unfortunately. When you look at the list of offenders, there's basically a one-to-one overlap with medications that have been identified on the Beers list, right? So I think medications that are felt to overall not be helpful for cognition in older folks are not helpful for delirium. There's a huge overlap. And I think that patients that are still on these medicines, sometimes people's hands are tied. There's so many reasons that people need some pharmacologic agent for X, Y, and Z reasons. So it is tough. My last slide, was one anesthesia focused intervention of trying to streamline meds from a particular delirium angle. I think it's complicated to think about doing that in the long term for a lot of patients because a lot of times these medicines have other uses, and I think in isolate, maybe switching it in the short term before hospital stay is useful, but then in the long term, I don't know the phasing back, what that looks like. That paper didn't really address what happens afterwards, right? Once you're out of the hospital, how do you phase people back into their medicines? Should you be phasing them back? Those questions are not yet answered. The reference, these slides will be shared. And so that reference, I think, did have some useful, although some medicines were very European and not used in the US, but it did have some nice ideas for ways of changing meds based on delirium risks. The studies are still quite small, and I think that just the data is not fantastic, but there are some thoughts about like opioids that are lower risk versus higher risk. Meperidine is really bad and high risk. Certain other like benzos are higher risk, and so we sort of just tailor as we can.
It's such an interesting idea. I went to the Society for Perioperative Assessment and Quality Improvement. I'm kind of new to this field of preoperative medicine. Mainly I worked in palliative care. I was trying to take a break. I'll talk about that during my case presentation anyway. But, I didn't hear any talk about that. And I would imagine it's because, like you mentioned, the evidence that supports having like hydromorphone instead of morphine preoperatively, or, getting somebody off an SSRI to get them on mirtazapine instead, like the cost benefit analysis of working with a patient in a short period. And it's also be really difficult, I would imagine, to see post-operatively, to be able to measure the benefit, because we wouldn't know what it would have been like if they stayed on their SSRI versus were on mirtazapine. But we do know that a lot of people have a very difficult time transitioning off of SSRIs. PCPs are scared to, switch people over to different opioids, I would imagine. But it's such an interesting idea. And theoretically, for the patients that I see in a preoperative clinic, that could be something that we could initiate with patients, or at least start a conversation with their PCPs in this setting. But we only see patients once, basically, and then turn them back over to the surgeon. So it's not like we have very much follow-up in a preoperative clinic setting.
Yeah. And I think, in the hospital, which is mostly where I sit, there's this tendency, right, to throw more meds at the manifestations of delirium, which can, in my opinion, make things worse. Your hands are somewhat tied. I think once the delirium starts, the behaviors are challenging for hospital staff, right? Your nurses, your nurse assistants. And so you want patients to try and recalibrate quickly. I think my opinion based on this is an opinion, is that it can be really hard to shorten the delirium with meds once it started to happen. You're kind of stuck with it until the brain works things out. And a lot of times more drugs can make things complicated. My general sense from reading this literature is that polypharmacy is more problematic than simplifying regimens. And I think much of the sort of pre-op, peri-op work that I've seen just tries to streamline, to say, instead of having multiple agents with multiple mechanisms in the same category, what can we do to just streamline, to say, okay, it's something that's relatively shorter acting, safer, one agent as opposed to multiples, to try and get away from polypharmacy in this perioperative, event.
I think this is a great opportunity for primary care providers to look at the medications, review meds, and then, look at Beer's criteria and everything else, and transition people to less harmful medications as they get ready for an elective surgery.
Yeah. I think I totally agree with that. I think that delirium is not really talked about, right, as this thing that happens so frequently in hospitals with such important and devastating outcomes. And I think that it could be a good reason. I do a lot of stroke care, and and so I talk about 10% risk of stroke with AFib, and we talk about Eliquis endlessly, and people take it very seriously. But I think we should be taking delirium very seriously. I just don't think it has the same platform as some of these other conditions that we treat that are more defined.
Yeah, I mean, we focus so much on cardiac and pulmonary complications. All these preoperative assessment tools are focused on that, but not so much on what happens right after surgery, and delirium being one of those conditions, with all these very, very significant downstream complications, as you mentioned, cognitive dysfunction and all those things.
Nancy, I was going to say,
yeah,
there you go.
Yeah, thank you so much, Hilary. Great talk. I wanted to follow up on a point that you made early in your talk regarding consent. And I think that's a wonderful sort of system level potential intervention for folks with elective surgery. We talk about bleeding and infection, but we don't really talk about delirium, and particularly for this audience where we're taking care of people with dementia or MCI, and whether it's a sort of lack of cognitive reserve and then the stress of delirium precipitating that worsening that's undiagnosed previously, or whether it's the inciting event, it doesn't really matter in a way in terms of that individual's quality of life, lack of independence, sort of functional decline. And so this idea that particularly for elective surgeries, it's that we as clinicians and at the system level are introducing this as a significant risk in the consent process, and kind of surfacing that awareness broadly, I think is really important. And, there's I'll just say this in one sentence, there's debate as to whether total knee replacement is superior in terms of outcomes compared to PT in some, analyses. So I think we can do a lot more too to really help our patients and share decision-making around approaches to manage these orthopedic conditions, these, lumbago and so forth, to support their quality of life and functional outcome and optimal cognitive functioning without that risk. Yes, you're seeing them in the hospital where the horse is already out of the barn.
Yeah.
Right. And we can't course correct often because of the lack of cognitive reserve in many folks, or that sort of neuropathological burden that has been accumulating over decades, as we know and have learned on many of our talks, So like, we really have an opportunity in the ambulatory care setting here to work, in shared decision making and to educate, and also with regard to the consent process, to think about this really carefully and judiciously. Because if you said to the patient, your knee might be better, but there's the potential that you may not be able to return to your own home. which is a real, I mean, risk in many cases, right? Is that a risk that somebody, and in hindsight, and we've all seen, I imagine most of us in this community have seen people who've experienced that. I mean, yes, where you've seen people after that surgery that's had this outcome where they've really had this subacute decline.
Yeah.
So I really think that's a great idea.
Yeah. And I made my slide a little bit busy, and because I know this is recorded and you guys have access to the deck, you know, the literature base is not as strong as we would hope, but I think these odds ratios, right, these relative risks are out there. I mean, they're validated. They've been shown again and again in a number of trials in the United States, internationally. So I don't think it's a question of whether or not this is going to lead to mortality or this is going to lead to cognitive decline for many patients. I don't think these numbers are out there. I don't think they're part of the discussions. And so I think that's one of the goals of this talk, is to kind of broadcast it a little bit more, to say, when you're having these discussions, I can't tell you, right, exactly if you're going to have delirium and if that's going to turn into more long-term post-operative cognitive dysfunction, but these are the risks, right? And the surgeon will tell you the risks of bleeding, walking, and so forth. We can tell you from a brain perspective, from a cognition standpoint, these are the risks of going into this procedure in the first place, right?
And this gets at two of the comments in the chat. One about, a tool for family members to talk about risks and to bring this up with surgeons and providers, and also Jamie's point about systems and policy change to be able to have a larger impact at maybe the systems level. So I think this has been super valuable to raise all of our awareness and maybe how we talk about this. So thank you so much.
No worries. And then to answer Karen's question in the chat, I'm just seeing the chat now. I will post a link in the chat. It's part of some of my slides, but the 2020 consensus statements from I forget it's a very long society that did them, but they have a couple of infographics to kind of talk about what from a systemic standpoint, based on their summary consensus and the strength of their evidence, things that can be factors to think about. So I can post that, and they have some nice, helpful, lay people friendly graphics.
Excellent. And Cindy, you mentioned a PDF that you use as well. I'm wondering if you'd be willing to share that with the community here.
Yes, I will.
I took a quick look and I couldn't find it, so would love to have that.
Okay, it's at my work, so if I can't find it today, I can find out how we figured out where it was at work next time I go.
No problem. Thank you. All right. And again, thank you very much, Dr. Wang. I want to be respectful of your time, and thank you for that link. Perfect. And we will indeed send out copies of the slides and the tools that we have discussed, as is our usual custom. All right. So with that, let me reshare my screen. And I am going to turn it over to Cindy Bevan, who is a palliative care nurse practitioner at Providence. And I'll drive the slides, but I'll let you walk us through it. And thank you, Cindy, for bringing this case.
Yeah, of course. And I work at PRMCE about a year ago. I kind of wanted to take a break from palliative care altogether. I've been doing this full time for about 7 years. But then one of my friends who runs a small home-based geriatric company, Carla Blue, she started a program called Novari Primary Care. She kind of convinced me to keep doing palliative care consults just kind of once a week. So this is a patient that I encountered when I was working with her group. So this is a 73-year-old woman who has frontotemporal dementia. She was I met her with her husband. This is how I learned all about her at a memory care facility. And so I got all the social history from him. She was diagnosed about 10 years ago. And after her diagnosis, her husband was her full-time caregiver for about 2.5 years. And since then, she's kind of been in a couple different memory care facilities. She did have a stint in an inpatient geropsych unit for agitation in the past. At the beginning of her disease process, her husband had noticed this he described it as a very quick onset. They were trekking in Nepal for about a month. The hike up to elevation, she was doing really well, and then it changed on the way down. He also said that she had stopped Effexor prior to going to Nepal, which he found interesting. And then once they came back from Nepal, her husband said that she'd become horrible to live with. She had very little medical history before this. She was a former preschool and yoga teacher. He described her as a big part of their community in Magnolia. They'd been married for 53 years. They had 3 sons who were living nearby and a support to her husband, and she was raised Catholic and identified as Buddhist, and that kind of belief system helped him and her make sense of things as she started to get sick. So like I said, medical history is pretty limited, just anxiety, depression, alcohol dependence. I didn't ask her husband how much alcohol she had been drinking in the past. So her medications kind of reflect her limited medical history here. It looks like what she was taking regularly was just lorazepam and baclofen. I think that's right. Yeah. So when I was doing my kind of narrative interview in palliative care mode with her husband, I asked him kind of, what's your perspective on where she's at right now? And he said that she's in complete non-responsive mode. He mentioned that she had been on and off hospice 4 times. When I met in March 2023, when I did some looking in her medical history, I have Epic access. It looked like she was admitted to Providence Hospice in 2019. And at that point, she was already 7E, or yeah, I put that there. And he couldn't remember what other hospices she'd been on, but that's what it's like when you're in Snohomish County. There's 4 different hospices and you've got a bunch that you could enroll in. And her goals of care were to have comfort focused measures. Her husband just was really clear that she just would have wanted to live this way if she knew what was going to happen to her. When we were having this interview, she was in her room with us at the memory care facility. She was in a Tilton space chair. She was very thin. I'd actually never seen this before in patients, dementia patients, but she was grinding her teeth constantly. I'd be curious to know if you all have seen this before, but it was very loud and disruptive, and it just must have been so difficult for him to have listened to for the past 10 years. He said that it had started a long time ago. And it's constant teeth grinding. She was able to make eye contact, not verbal, no purposeful movement at all in any of her extremities. She hadn't been hospitalized for years. And the most recent labs I'd seen for her were from 2 years ago. He found this to give to me to kind of prove that she was getting overfed. Obviously in the months leading up to us meeting, she had gone from 91 pounds to 92.7 to 96.9. If you're anything like me, you just know that it is so difficult to get weights on people who are Tilton space chair limited, but nevertheless, you do see a trend with her weights from back when she was on hospice up until now. It's going up slightly. So there's that. So he did talk to me about, at the time, he said, I don't want her to have any more nutritional shakes. And so I said, I think that this is an order and I don't see any reason why we should continue these nutritional shakes. I don't necessarily see, I don't think that, given the fact that her priority is comfort, that this is something that we really need to be giving to her. These are expensive. So at that time, when we met, I wrote an order to stop the nutritional shakes. He wrote me an email kind of as a follow-up of our conversation and it was also like a summary of the discussion that we had at the facility as well. He'd mentioned this to me, that he had talked to 3 of his doctors, just kind of informally, talking to them about how distressed he was that his wife was still alive in the way that she is, and that he said that his doctors all agreed that he has the right to decide what his wife would want. They've been married for 53 years. He said that he's sure that she wouldn't want this imitation of life. And what he wanted was that the facility would restrict her food. He wasn't sure how. One idea I had was asking that they only feed her lunch and that we not be quite as aggressive even then. When I feed her lunch, I work on it for over an hour and I only get about 1/3 of her meal into her. I'm told that they get 100% or close. So he was like, why are they feeding her so much? Or how is it that we can get this much food into her when he comes at lunch and he's only able to get a little bit of food into her? And so when I got this email from him, this is when I actually first reached out to you guys, because I was like, I don't know really exactly how to handle this. Like, how should I talk to him about this? And kind of what I came up with, this was back in March, was, you know, these facilities, they have their policies, right? So even though I'm able to write orders for patients, I can't go in and ask them, like, don't feed this resident food, for example. I was never really able to get, and these facilities, you know, they have strict policies that kind of go across all of them of how they handle patient care. And so I told him, you know, I'm quite sure that restricting her feeding to only one meal is not something that this facility is going to be able to do. You know, obviously, if she was living with him still, he would be able to feed her kind of as he saw fit, which was another interesting thing for me to kind of wrap my mind around, is that, like, because this woman is living in a facility, needs 24/7 care versus at a home, you know, the amount that people are fed, it could really change. And that has some kind of ethical implications, I suppose. And another thing that I started wondering was, you know, how much of, because his concern is that, you know, she's alive, something that I was wondering was really, what's the correlation between how much people are being fed, like their caloric intake, and then their prognosis at this point in their dementia process? Because I tried to tell him, like, I'm not aware of any research that says that, you know, the less people eat, you know, short of like voluntary stopping of eating and drinking, I'm not really sure that she's going to live any less. And he said, well, I'm quite sure that that would happen if, you know, the facility stopped feeding her. So anyway, that's just a lot of kind of free form thoughts from me. You know, in the end, he was really happy with, you know, just knowing where we're at now. She was admitted to Providence Hospice back in May, or Evergreen Hospice back in May. I'm not able to see Evergreen's records, so at least you know, he's getting support from the hospice nurses, and he was okay when I kind of went back to him and said, there's nothing that we can really do with the facility and like making them stop feeding her.
All right, Cindy, thank you so much for bringing this forward. And I'm sure there's a lot to discuss here. And I know Mimi's going to have some thoughts. So I want to come back to that before or after we give our community a chance to ask any questions, anything that you want to know about this particular case.
Can I just add one more thing? I forgot to, this
sure.
is actually a huge thing, is I told him that I feel like if we were to stop feeding her, that feels like we would be starving her. So I said, you know, kind of the way that we think about taking care of people with advanced dementia is that we offer them food. So it sounds like, based on the facility report, is that they feed her and she eats. So that to me means that this is something that she would like to do. So for us to take that away would kind of be the equivalent of withholding feeding of something that she would like, of the life that she does have. She's communicating this is something that she wants. So that was actually a big crux of our conversation that I forgot to mention. Okay, that's all.
No, that's a wonderful point. Wonderful point. Other things that people would want to know about this particular case? Janine.
Hey there. I am wondering if a dietitian was involved at all at the facility. I may have missed it, just to get their input on portion size, that kind of thing.
I'm not aware of the terraces having a dietitian. I could be wrong, but I've never had any interactions with them. Is it pretty typical? You know, this is the other thing, is that with these memory care facilities, so much of the care they get depends on the facility. So I'm not even sure that they have one. And they could, but I've never interacted with them.
And just some input I have, it's interesting. I have an early onset dementia patient who had bruxism and was reflexively eating and gaining weight, and did some education with the facility about, you know, it's not because she's hungry necessarily, but she might be, you know, unaware of how much she's eating, and just getting the dietitian involved and doing some portion control to keep her having balanced meals without, you know, restricting food, just getting it a better portion size. And we ended up using baclofen and finding a dose that was keeping her more relaxed in her muscles and not too sleepy.
Right. Yeah, my patient, this woman is on baclofen 3 times a day.
Yeah.
So you're saying there's a correlation between the bruxism and overeating, or
Well, no, I don't know, but my patient happened, she's still alive. She happened to have both of these things. I think the dementia was the overeating and just reflexively eating and gaining weight without being hungry, but also she does still have bruxism, and we're controlling it with baclofen. But it was trial and error to find the right dose to help keep her mouth.
and that helped her, huh? Yeah, this has been so chronic with this woman. I hadn't even considered working with her baclofen, maybe increasing it to see if it made any difference.
Yeah, I'm also wondering if any of our community members have any recommendations about that in terms of experience along the same lines. I'm thinking of you, Kimmy, or Nancy, or.
I've had a few folks with very bad and longstanding teeth grinding, and the family members have been very informative. But usually, it's trying to find safe things for the person to chew on, so that the teeth don't get too worn down. But it's pretty tough. One person seemed like it was maybe kicked off by a dental procedure. That there was something after that just sort of kicked off this behavior.
Any other questions about the case? We've got about 13 minutes, which is probably just about the right amount of time to talk about your larger questions or recommendations. And Mimi, I see you came off mute. If you want
I did.
Yeah.
Thanks. Oh, Cindy, thank you for bringing this case to us. It just has so many aspects that are so common and such a source of, I think, moral distress for different people at different levels. And I'm really interested, I don't know if you know this, why she was on hospice or why she came off hospice 4 different times. I mean, typically it's precipitated by an aspiration pneumonia and someone like this who has such advanced dementia and is in a, immobile in a tilt and space wheelchair. Do you have any idea, was that the
I
reason?
know that with Providence, she was discharged for failure to decline. The one time that she was on it, I mean, she was already 7E. I guess she just wasn't losing any more weight. I'm not exactly sure what the assessment was there after her, I guess, like her 3rd
Right.
period.
And that's our frustration with CMS, is the next decline is dead.
Yeah.
Oh,
yeah.
and there isn't any point in between to document, if you will. So that's just another frustration. With the facilities, you are so right. And if it is their job to feed these people and to really keep and give them nourishment and keep them alive, it's their job. And they're going to continue to do that. And in our experience down here, it's very, very difficult when families bring up the idea of potentially not feeding. The whole idea of force feeding, I find it interesting that she doesn't eat well for him, but she is supposedly does. And by virtue of the fact she is gaining some weight. Yeah. And like you said, for him to take her home and be able to feed her kind of when she's hungry, as opposed to on a regular basis, is typically how we counsel patients and families. And I have one other thought.
Well, how would he know when she was hungry? He's trying to say that she's like not hungry. But obviously she's at a facility, so she's going to get fed the same 3 times.
Yeah.
A day.
And to offer her foods that she likes from the past, to have a bite. I mean, in general, that's what satisfies people with dementia. And, getting nutritional supplements, I know of no data that suggests that this is good for them or even prolongs life. But I know we have some adult family homes where these people are cared for. Their skin is meticulously cared for, their turn, it reduces their risks of aspiration and all of that. And they take 1 to 2 hours to feed. And they do live longer than our other patients who don't have that kind of care, that personal care. Yeah.
It's so interesting how so many of these facilities, they just kind of have this reflex. If there's any weight loss, they're getting started on nutritional shakes, you know.
Exactly.
family
Yeah,
home.
they fear being cited
Yeah.
for weight loss. And it's part of the natural course of the disease. And at some point in time, this woman isn't going to be able to swallow. She
Mhm.
is not going to be able to eat. And, you know, the whole thought, and there's more and more discussion around that today with some people choosing voluntarily to stop eating and drinking. And if my loved one said this a few months ago, now can't make that decision, and in fact asked for food, should I abide by what they said 6 months ago, and the dilemma around all of that and the guilt and all of that? It is so complex. It is.
Yeah, I was so worried he wanted the facility to stop giving her food altogether and drink altogether. And I was like, that is going to be a lot harder conversation if that's really what he wants for her. Yeah.
You know, I think the question is, how can
okay.
we best give her comfort feedings and not force feed her?
Right.
Is the teeth grinding contributing in any way, and can anything be done about that to help with that, so people aren't interpreting that as I want to eat?
Very good point. I'm seeing in the chat, it looks like Karen Hayes, you had a similar kind of set of questions. Did that answer? Okay, great. And then Allison, you're wondering about if anyone's looked at jaw alignment. Do you want to say a little bit more about that?
Yeah, so I have a thing with my own mouth where when I grind my teeth and my jaw kind of misaligns, and so then I'm trying to get it back in, and I have the ability to use my hands to massage my jaw and get it back in. And at a recent conversation with my dentist, she's like, I hear this all the time from people whose jaw gets misaligned, like in their sleep, they wake up and their jaw is misaligned, and so they use their hands to gently massage it and get it back in. And I can imagine that if I didn't have the capacity to do that anymore, that there'd be discomfort there, and I'd be like constantly trying to make it happen. So I just wonder if there's something else going on in there that just hasn't been looked at. And I mean, all the obvious stuff of like checking to see if she has a tooth, like, does it actually feel good to chew because it relieves some pressure from something that's going on in her teeth? So I assume that that's all already been looked at. But I'm just curious whether or not there's something else going on in there.
I don't think that's a safe assumption to make. It underlines how difficult it is to get dental care for folks in memory care facilities. I feel like I just really want to, is there like a dental 101 for providers to take so I can learn how to do, like, at least figure out like some basic interventions? Yeah, next time I see her, I could try to massage her jaw. Like, I don't know exactly if that what that would do. It's fine. I just got Invisalign like less than 48 hours ago for like a similar reason too, but anyway.
Yeah. Well, you know, there are dentists who do house calls and who will go to care communities. I know that I don't know if she still travels, but I found a dentist who was amazing, who really works well with people with dementia. And I took my husband there every 4 months, just every 3 months, just to get a full like thing going. So I don't know. There are options out there if they wanted dental care.
Mm-hmm.
That is a good question, and so hard when somebody's nonverbal too, right? In terms of how do you assess these things? How do you ask about these things? I also see that Erica Campbell put some resources or a link to some resources for safe chewing objects in the chat too. So thank you for that. And then Christine, looks like you got a comment.
Yeah, so I work at Furcrest and I have a lot of nonverbal patients. Actually, most of them are nonverbal. And I have several patients who do grind their teeth, and fairly loudly and fairly frequently. And I don't know that I have an answer for it, except I feel like for some of them, there's an internal stimuli or a sensory need that they're getting met with that motion. And so I just wondered if there was something else maybe in her that's going on. I mean, we know she has dementia, right? We know that she's declining that way, but is there something else that we could potentially help her with another medication? Is she having any signs of like hallucinations or psychosis or just anxiety over being trapped in a body that she can't control anymore? So I don't know that that really helps anything. I just know that I've seen it quite a bit, or at least several of my current clients have significant teeth grinding, and I just look at them and think, that just sounds like it hurts just to be grinding your teeth in that like kind of tight or that wound up about whatever it is. And it's hard to know because they can't talk to you.
Right. It's just so loud. You know, a lot of these medications that were treated, they're like on the Beers list. Obviously, it's not things that we would want to necessarily give somebody, or yeah, they could exacerbate their delirium or exacerbate anxiety. But she takes lorazepam 3 times a day.
Yeah. Well, and the other question would be, would it change? I mean, she's in palliative care, right? So like, does it change her quality of life to do that?
Right, right.
Yeah.
Other comments or thoughts? Karen, looks like you put something in the chat. Do you want to expound on that a little bit?
Sure. I put in the chat the link to the special Washington State Special Needs Dentistry Directory, where you can kind of put in the special needs, and it is a Washington State resource.
Fantastic. Thank you for that. Cindy, do you feel like you've gotten what you need here, or are there other things that are still lingering? These are such tough topics with no clear or easy solution. But
yeah, you know, I guess I kind of wanted to just share this because it feels good to be able to talk about it. I'm not sure if there's like any answers that I was expecting to get after coming here, besides just kind of sharing. Because yeah, I only do palliative care once a week now. I'm the only one that really does it for Nobari. So I'm happy to get back involved with ECHO again.
well, we definitely appreciate you bringing it forward. And
Yes, thank you.
yeah, well, and you know, I think about the mission of this program, which is to improve the care for people in our rural, underserved communities and less resourced communities. And I think, you know, you're a great example of providing wonderful care, thoughtful care in a very difficult scenario. So thank you for that.
Thank you.
Well, we got a couple of minutes. Oh, here, I'll share the last slide maybe, which is our next session, which will be July 12th, I think it is. Yep, excuse me, 14th. And that will be legal planning with Meredith Grigg, attorney at the Northwest Justice Project. And she has been wonderfully involved with the Dementia Action Collaborative and a major participant in the legal planning toolkit and its dissemination. So I'm looking forward to that. It should be quite good. And as always, you'll get a 1 minute, very brief survey if you haven't already. And we will plan to see you next Friday. And thank you all for your participation. Oh, and it looks like Allison just put the survey in the chat. So very good.